Good morning, everyone. I greatly apologize for not being able to be there. I'm very sorry about that, but glad for the opportunity to talk to you about the pathology of what we're seeing in the cohort that Vivian nicely discussed in the prior presentation. And so I want to give you some more details about what the pathology is of lung disease in this cohort, but also kind of give you a background of some of the entities that may or may not present with similar manifestations, with the whole idea of trying to understand what's going on and what's eliciting this lung disease in sJIA. So I am a pediatric pathologist, and my particular interest is lung, and I've been very fortunate to work with the Children's Interstitial Lung Network since 2005. So I've seen a lot of lung biopsies and get a lot in consultation. So the important thing to remember when you look at systemic disease processes like sJIA is a multi-compartment disease process. And this is definitely what we see in pathology. Sorry, go on to next slide. I apologize, I have to remember to say that. So here you're looking at a section of lung and then a schematic of lung on the left. And essentially, there's different compartments of lung, including the pleura, the pulmonary vessels, the alveoli, the airways, and the lymphatics. And essentially, connective tissue disorders involve all of these compartments to some variable degree. Next slide. So we know quite a bit from both case reports as well as large case series, as was reported by Camara, as well as also the child.
Gail, yeah? Can you just pause for a moment?
Sure.
Betsy's asking you to come back to the multi-compartment disease slide.
Okay.
So if you could just say that again.
Say what I said about it, or So I was just saying that that the connective tissue disorders involve multiple compartments of the lung, including the vasculature, the airways, the pleura, and the airways, and that gives us a good clue that it is indeed a connective tissue disorder. So next slide. So we know, based on the case reports as well as the large case series that have been reported, including by Camara as well as the Child's Interstitial Network, that there is several manifestations in terms of the pathology of sJIA. They definitely have pleural disease, often in the form of pleuritis. They have variable interstitial lung disease, and you've heard a lot about pulmonary alveolar proptosis and endogenous lipoid pneumonia, which I'll talk more about. They have airway disease, and predominantly in the form of organizing pneumonia and peri-airway fibrosis. And then, of course, vascular disease, which presents clinically with pulmonary hypertension. And then, of course, the bane of all disorders that are in immunosuppressed patients are they have frequent opportunistic infections. Next slide. So the advantage of having this cohort, again, having a big series to review the pathology of, is that as Vivian explained, in conjunction with all the reporters she's worked with, as well as all the other people at the institution, these are very well-characterized patients with sJIA. So next slide. So we can ask the question, and I think we already know the answer, are there common lung phenotypes in pediatric sJIA? Next slide. Are there lung phenotypes that have a worse prognosis? And again, we're talking more about pulmonary hypertension, though as Vivian inferred that alveolar proptosis also seems to have a poor prognosis. Next slide. What drives the development of PAP and endogenous lipoid pneumonia and other pathology? And of course, that's the critical question we're all trying to get at. And next slide. And these things, of course, has been inferred, it's thought to be drug-related, but I think there's probably going to be multiple factors involved that are going to be hard to tease out. Next slide. And then, of course, getting at what the immune cells are involved in the disease process because, obviously thinking about in the setting of this conference, potential therapeutic targets. Next slide. So the diagnostic challenges when you're looking at the pathology of these patients with these disorders is that you're likely looking at multiple different factors involved. Certainly manifestations of the patient's systemic disease process, but also likely you're looking for concurrent or superimposed opportunistic infections, and then, of course, getting at the issue of drug toxicity related to the medications that these patients are on. And it's important to remember that the drug toxicity can cause a very variable pathology in the lung that inadvertently overlaps with the pathology that's described in the systemic process, or what's known, for instance, nonspecific interstitial pneumonia is both a common manifestation of connective tissue disorders, but it can also be a manifestation of drug toxicity. So it can be extremely difficult to tease out what is causing what. And then the other thing we have to remember, and this was discussed by Chris a little bit, is that the lung is growing in these children. Indeed, that lung development continues well into the perinatal period, certainly for the first 2 years of life, but even likely further on. And so whatever is going on in these children's lung disorder is likely impacting their lung development as well. So that's another thing we have to keep in mind as we're looking at these cases. Next slide. So hopefully the slide you're looking at now is the graph of the sJIA cohort review. Here what I did is I classified the 31 cases that had a lung biopsy and or autopsy, so I didn't include the ones with bronchoalveolar lavage or unknown based on absence of lung biopsy. So if you look at these 31 cases and you classify them by the predominant pathologic features, that being said, they all have features of all have other manifestations that are not as prominent. But essentially what the message you're already hearing from the conversations, the talks that have preceded me, is that PAP and endogenous pneumonia, or the spectrum thereof, is the predominant pathology in this cohort of patients, as well as vasculopathy and then other disease processes. Next slide. So what are the other disease processes? Well, here on the left, you're looking at a case with a necrotizing granuloma, and there was fungus in that case that we were able to find, so an infectious complication. On the right, this is a case of a patient who actually was from Seattle, who had mixed interstitial inflammation as well as organizing pneumonia, which you're seeing with the arrows. That's the fibroblastic plugs of tissue. And in this particular case, that organizing pneumonia and fibrosis was thought to be related to the methotrexate the patient was on based on the timing of the injury. Next slide. And then also we're seeing things that we're not sure what the etiology is. Here's a case, again, from Seattle where we're seeing fibrotic interstitial, not what we call NSIP, nonspecific interstitial pneumonitis, where you're having diffuse interstitial expansion from fibrosis, which is why all the alveolar septae look thickened. In this particular case, it was very patchy, but there was some proteinaceous debris as well as cholesterol clouts, which you can see in the spaces where there's little jagged lines as well as pink debris in there. And so the message, again, is that even though, we're not classifying these cases as PAP/endogenous lipoid pneumonia, that many of these cases have these kind of features, at least focally or even rarely in the biopsy. And again, it's just hard to know how to tease it all out. And then on the right, you're seeing a case of acute fibrinous pleuritis, as well as airway injury, which you're seeing in the middle. And again, these are very common manifestations that we saw in almost all the patients. Again, though, that wasn't the primary disease process. Next slide. So you've heard about pulmonary hypertension, and certainly that was present in quite a few cases that we looked at. And this was not subtle hypertension. This was quite severe. So on the left, what you're looking at is a pulmonary artery, and this particular stain, called a Movat pentachrome stain, it nicely highlights the normal wall thickness of the artery, which is where the black lines are, and then all the middle area, which is filled in by this kind of purple, brown or reddish material. That's all intimal hyperplasia of the vessel. So very abnormally thickened, not allowing a lot of blood flow. And then on the right, what you're seeing is a fatal case of veno-occlusive disease in another case, in which the veins are actually filled in with fibrous tissue. And again, there's obstruction of blood flow out. So that would be another instance of what we've been seeing as well. And here's some more examples of another case, both with occlusive changes of the pulmonary arteries on the left, and then veno-occlusive disease on the right. And this veno-occlusive disease in particular is often a fatal disorder. Next slide. And then again, I just want to remind you that even when the primary pathologic process is often vascular, the vasculature, as in the case of Boston 2, which has very prominent intimal hyperplasia, we also saw this, what we're calling endogenous lipoid pneumonia on the right, even though it was patchy, where you have this very thickened alveolar septae with inflammation and then deposition of cholesterol clefts and lung remodeling. So that's what I want to spend some more time talking about now, is this kind of distinct pathology about PAP and endogenous lipoid pneumonia. Next slide. So the term pulmonary alveolar proteinosis, or PAP, what does it mean? From a pathologist standpoint, it means this finely granular lipoproteinaceous material that fills the airways, both proximal and distal. It doesn't always, but it frequently contains cholesterol crystals as well as cellular debris and inflammation. And you may have associated reactive type 2 cells as well as alveolar remodeling and fibrosis, especially when it's a chronic process. Next slide. So the etiology is quite diverse, actually, even though typically people think of it as being related to surfactant production disorders, or rather genetic surfactant production disorders like surfactant protein C and B and ABCA3 and others, and GM-CSF receptor. But also it's very frequently related to disorders, or probably more frequently, that impair surfactant clearance, because you either have abnormal numbers or you have defective phagocytic function of alveolar macrophages. And this is best known in the setting of GM-CSF antibody signaling issues, but you can see it in a variety of entities, which I'll show you, including immunodeficiencies, infections, and toxic injury. Again, that impairs the ability of alveolar macrophages to clear the material. So next slide. Next slide, you should hopefully be seeing the classic things we're calling pulmonary alveolar proteinosis in this sJIA cohort. So both on the right and the left, the right being just a higher power. You're seeing alveolar filling by this pink material, which is interspersed with cholesterol clefts and just very few macrophages in there as well, with or without some type 2 cell hyperplasia, which I'll talk a little bit more. So this is the classic pulmonary alveolar prognosis. And then if you go to the next slide, you're seeing other entities where we use the pathology term of pulmonary alveolar prognosis just for comparison. So on the left is a case of a pneumocystis pneumonia, and in this particular case, all that fluffy material in the alveolar space is a little more bubbly than what we're seeing in the sJIA cohort. It's got more bubbles, and you're seeing the silver stain that's highlighting the pneumocystis organisms. And as Vivian said, in all the cases where I had extra slides where I was able to do immunofluorescence for PCP, I did that, and we didn't see any organisms. On the right side, you're seeing a patient with AML, acute myelogenous leukemia, who had prognosis. And again, it's patchy, not unlike our sJIA patients, and it has some of that cholesterol cleft. So again, there's a more similar type of appearance of PAP, but something we would call by when we're reviewing the pathology. If you go to the next slide, so now I want to talk about endogenous lipoid pneumonia and cholesterol granulomas. And while we traditionally think of this as being separate from PAP, actually there's quite a spectrum of features that significantly overlap, and that's why we're kind of coalescing these entities in this disease process. So the pathology is a bit similar to PAP in that you can have lipoproteinaceous material, but you also have more exuberant filmy macrophages and cholesterol clefts that are deposited in the spaces. And again, there's often a fibroinflammatory response. If you go to the next slide. So the etiology of endogenous lipoid pneumonia and cholesterol granulomas, again, is quite diverse. It's caused by cell injury, and what happens when you get alveolar wall injury, you get release of lipid and then uptake of alveolar macrophages. We see it quite frequently in the setting of airway obstruction, like organizing pneumonia, for instance. We also see it in the setting of just infection and drugs due to, again, alveolar wall injury, and then other disorders, including genetic surfactant dysfunction disorders, which I'll show you a little bit later. Next slide. So here's what endogenous lipoid pneumonia looks like in the sJIA cohort. Again, left side showing a low-power image showing diffuse, I say diffuse alveolar filling, but actually it's patchy but extensive. And then on the higher power on the right, what you're seeing is versus that prognaceous material, there's more macrophages in the air spaces and then some cholesterol clefts. And in this particular case, you're seeing very prominent reactive type 2 cells lining the alveolar spaces. Next slide. So you can, like I mentioned, you can see it in a variety of other entities. And here on the left, you're seeing similar cholesterol cleft and proteinaceous material in the setting of a severe lung growth abnormality, not unlike you might get in some cases of pulmonary hypoplasia. The mechanism in this case is these patients have very poor clearance, and so things get trapped in their alveoli, and then there's alveolar wall injury, and you get this debris as you're seeing here. And then also, again, injury-related, on the right, you're seeing some similar kind of cholesterol clefts, except here associated with some foreign body giant cell reactions in the setting of hypersensitivity pneumonitis. Next slide. So probably, as you know, and a lot of you think of, when you think of pulmonary alveolar prognosis, you think of surfactant dysfunction disorders. And again, I spoke of this a little bit. Again, these are molecular defects that affect surfactant synthesis, assembly, metabolism, and clearance. And there's a variety of them, and there's still a lot more to be described. So the classic pathology people think of in the setting of these genetic disorders is pulmonary alveolar proptosis, and here you're seeing actually a GM-CSF receptor deficiency that I'm showing with very little remodeling. But if you go to the next slide, what you're seeing is more typical case of what we see in the setting of neonatal surfactant dysfunction disorders, or those that present in the neonatal period. And here's a case of an ABCA3 mutation with what we call PAP, pulmonary alveolar proptosis, but here it's a little more chunky, and there's quite a bit of exuberant lung remodeling. And in our cohort, where these patients presented very young with ABCA3 mutations, it was uniformly fatal. If you go to the next slide, you're looking at a surfactant protein C mutation. There, the pathology is not so much a proteinaceous material, but it's more of a foamy macrophages and cholesterol clefts. So kind of endogenous lipoid pneumonia-like, but what we call it in the spectrum of surfactant, again, this is old terminology we use, is chronic pneumonitis of infancy. So although I'm showing you particular examples of chronic pneumonitis of infancy associated with surfactant protein C and PAP associated with ABCA3, I want to make it clear that all types of patterns of pathology can be seen in all the different surfactant mutations. So it's not specific. You can see a variety, and there's no known association that we know of at this time associated with what their particular genetic mutation is. Though, if you go to the next slide, I will tell you that patients who present older, at an older age, with a surfactant mutation have a more fibrotic pattern of injury. And so this patient was probably about 2 years of age, presented with respiratory symptoms, got a lung biopsy, had more of what we call an SIP pattern with interstitial expansion by both inflammation and fibrosis, but the arrow is showing you also has some proteinaceous material and was found to have a surfactant protein C mutation. If you go to the next slide, what you'll see is a case that Lisa Young and I reported of a 15, I believe he was 15, who presented at that age actually with clubbing and respiratory insufficiency, had actually a pattern of UIP, so IPF in adults, very unusual in children, and this patient was found to have an ABCA3 mutation. So certainly we don't really understand a lot of the nuances of the pathology and the surfactant mutations, but we do have an understanding that there appears to be an evolution of features, and that if you go to the next slide, that as life evolves, as kids get older, they tend to progress to more fibrosis and remodeling. So if you go to the next slide, what I'm trying to get at is, can we learn from example of what we've other better characterized disorders? So we have our sJIA cases. We have a spectrum of pulmonary alveolar proptosis and endogenous lipoid pneumonia. How can we take a look of compare that kind of pathologic features with other ones like, next slide, infection, next slide, genetic surfactant mutations, and next slide, going to things even like juvenile rheumatoid arthritis, not as far as I know associated with systemic JA. Here's a consult I reviewed, which had a very similar pathology, again, very patchy prognosis, again with the cholesterol debris. And then on the right side, a GATA2 mutation, again, immunodeficiency, immaturity or dysfunction of myeloid precursors, causing a very similar picture, very patchy but severe fibrosis, cholesterol debris, remodeling. So what can we learn by, comparing our case series to these known disorders? Next slide. And so I'm really starting to just get at the beginning of this process, but I can give you some general features that I'm seeing when I talk about PAP and ELP.
Hey, Gail.
Yeah.
Pardon the interruption. Can you? The folks in the audience are asking if you could go back a slide, please.
Yes.
Hold on.
Okay.
Hold on a second. I also want to let you know that we're coming up on time. We've got about 4 minutes till the end of your time, and I want to
I'm
make
almost
sure.
done.
Great.
Mhm. I'm almost done. Mhm.
So if you could just use either numbers or words and let us know which slide you are talking about, that would be great.
Okay, so the slide where I say learning example, by example is slide 24. And that's showing JRA on the left and GATA2 mutation on the right.
Great. Thank you very much. Please continue.
Okay, so if you go to the next slide beyond that, which I guess is 25. So some of the general features that I have observed by reviewing all these cases together is that this is invariably a patchy process. So there is lung sparing, and it doesn't appear to be, although on the right-hand side what you're seeing looks like airway-centric, a lot of the injury is around the airway. That doesn't seem to hold up when you look at all the cases. Next slide. The other thing I'm seeing is variable acute and chronic inflammation, though frequently lymphoplasmacytic inflammation often seems more prominent, but you do get quite a bit of acute inflammation as well. Next slide. And then variable reactive type 2 cells. And so we talked about a little bit what Chris talked about a little bit about what GM-CSF receptor deficiency looks like, but here on the left side, this, I think if you got this slide blinded, you wouldn't be able to distinguish this from a GM-CSF receptor deficiency. It's quite prominent. So this particular patient, I believe, died, but had almost no reactive type 2 cells. But then you do have quite a variability in that. And then again, the arrow on the right is pointing to the reactive type 2 cells. Next slide. And then again, often associated with the proteinaceous material is lobular remodeling with fibrosis, which is variable. On the left, you're looking at interstitial fibrosis, and then on the right, a patient, again, who died, is basically quite advanced fibrosis with honeycomb change, so pretty advanced fibrosis that can happen in this particular patient who was 7 at the age of death. Next slide. And then I just want to remind you again, this is not just one entity. This is a multi-compartment process in every single case, which leads us to believe this is sJIA and not some other disorder like a genetic disorder or surfactant dysfunction disorder, for instance. And almost all these patients had some degree of pleural thickening or inflammation, and then many had vascular changes as well. Next slide. I just want to quickly say two things. I did go about looking at the ultrastructure of these cases, which I'll show in a second, as well as I did surfactant stains, which can be useful in a small setting, a small subset of surfactant dysfunction mutations, and I didn't see any abnormalities. So on this slide, what you're seeing is a classic case of abnormal lamellar bodies on the right. This is ultrastructure of a type 2 cell. And this patient has a lethal ABCA3 mutation. They have very small lamellar bodies with dense bodies. But if you go to the next slide, what we're seeing in the cohort of sJIA patients, if we look at their ultrastructure, is absolutely normal lamellar bodies, which you're seeing on the left. So these type 2 cells have normal lamellar bodies. What they do have, which is very interesting, which I guess goes along with what we're seeing on the histology, is that they have very lipid-laden macrophages, which you're seeing kind of on the up-hand panel on the right side. And if you go to the next slide, a lot of these macrophages have cholesterol clefts. So definitely macrophages filled with not only lamellar debris, but also lipoid debris and cholesterol debris. Next slide. So no doubt there's a lot more work to be done, but to summarize the pathology, we see patchy but extensive pulmonary alveolar prognosis / endogenous pneumonia, as you've heard from the prior talks, is a very predominant pathologic feature in these patients. It's associated with variable mixed inflammation and type 2 cell hyperplasia and fibrosis. That being said, this is a multi-compartment process and very frequent pleural as well as vascular findings. And the things we really need to keep cognizant of as we take a deeper dive into looking at these patients is that the patient's variable age and presence of other disorders like trisomy 21, where they frequently have a subpleural cystic change, should be considered when we're interpreting these findings. Next slide. So thank you very much. And again, I apologize for the awkwardness of the remote presentation, but I appreciate the opportunity to talk about the pathology.
Thank you so much, Gail. We have time for just 2 questions. I'm just going to remind our folks in the room to please introduce yourself.
Hi, Peter Nigrovich from Boston. Thank you for that great presentation. Have you had a chance to do immunostaining to see what the lymphocyte populations are? So I'm thinking specifically we've heard about gamma delta T cells, we've heard about CD8 cells and NK cells, and whether you have any cytokine staining opportunities or megakaryocytes. Thanks.
We have not looked at that yet. We're trying to plan what makes the most sense to start with study-wise in terms of markers, but that's definitely in the works of planning, but haven't done it yet.
Hi, Gail. It's Chris Tao.
Hi.
Hello. So I really like to talk about the compartmentalization of the lungs because as a clinician, I try and compartmentalize my patients' symptoms, thinking about what their symptoms are telling me about which compartment of the lung is impacted. And currently we're seeing more and more patients who are presenting with cough, which I think of more of a bronchitis feature, less so of a PAP feature. And so you made mention that bronchitis wasn't very prominent. Do you have any quantification for how prevalent it was or was not in these cases?
I would say it was not, certainly there were patients that had quite prominent airway disease in terms of organizing pneumonia. There was also a couple of patients who wound up having autopsies where and I showed one picture of this, where the proteinaceous material was very airway-centric, and there was invariably effacement of the airways by inflammation. So I kind of have a sense that I don't know if you can generalize that if it's not, if it's airway, it's not PAP, because I think it's just kind of how this process evolves tends to wipe out certain structures, basically whatever in its way, because it's completely obliterating a lot of these airways.
Okay, that's all the time we have, Gail. Thank you again.